Good morning, everyone. At the outset, I would like to thank the organizers, especially Dr. Creighton, Professor and Head of Dermatology, Amla Medical College, Stressors, who is the course director for this national webinar. So psoriasis, as you know, is a chronic T-cell mediated inflammatory disorder characterized by benign epidermal proliferation. As evident from this slide, you can see the psoriatic epidermis several times thicker than the normal skin. So it usually develops in a genetically predisposed individual and precipitated by several factors, like focus of infection, trauma, stress, metabolic factors like hypocalcemia, and extremes of weather, and usually in winter. Psoriasis affects both sexes equally. It's seen in about 1 to 3% of the global population. It's a slightly higher incidence in HIV, about 5%. Even though it can occur at any age, there is a bimodal onset of lesions. The early onset, the most common age group is 60 to 22 years, and late onset by 57 to 60 years. That's a famous Roman writer, Aurelius Cornelius Celsus, who has described psoriasis in the classic textbook of medicine, that is De Medicina. And it was Robert Willen who introduced the classification system for diseases, and he has introduced psoriasis under the chapter squamate in this book of cutaneous diseases. And the name psoriasis was actually given by the Greek physician Claudius Galen, and the psora, the word meaning itch, even though it's actually a misnomer. Coming to the clinical variants of psoriasis, these are the several types: chronic plaque psoriasis, the guttate psoriasis, inverse or flexural type, seborrheic, the pustular, arthrodermic, and arthropathic types. Of these, the most common, as you know, is the chronic plaque psoriasis, also known as psoriasis vulgaris. Vulgaris, I hope you all know that meaning, common. This is characterized by well-defined erythematous plaques of varying sizes with typical silvery white or micaceous scales. And the common sites are the bony prominences like elbows, knees, the extensors, the low back, as well as the scalp. This is a patient with a typical psoriatic plaques with silvery scales on the scalp and face. Usually, facial lesions are not very common like this. Here also you can see multiple plaques which have joined together forming polycyclic or annular patterns, mimicking even the subacute cutaneous LE lesions, the psoriasiform lesions of SCLE. But the silvery white scales are very prominent here. Here you can see multiple scaly plaques on the scalp, that is scalp psoriasis. Childhood psoriasis may differ slightly from the adult psoriasis, being more pruritic, and the plaques are usually thinner and less scaly. And there is increased chance of involvement of flexures, face, scalp, and genitals. And the most common precipitating factor in children is the focus of infection, mainly streptococcal. You can see this girl with a typical psoriatic lesions, the thin plaques on the face, which are less scaly, lesions on the thighs and the involvement of the groins. Flexural psoriasis also very common in children, and this is the most common type in children. That's the guttate psoriasis, small raindrop-like lesions. And there's another boy with lesions on the neck and the thin plaques with less scaling on the dorsum of hand. The same boy, another boy with a multiple scaly, thin scaly plaques. So the typical sites, the elbows and knees. Pustular psoriasis, especially the ectodermatitis type, is also very common in children. So you're seeing here linear lesions with silvery white scales. These are the lesions developed at the sites of trauma, classically known as the Koebner phenomenon, which can be seen in several other conditions like lichen planus, vitiligo, eczemas, and so on. So why this name Koebner? It was described by the German dermatologist Heinrich Koebner. This is usually seen. This phenomenon is usually seen in the acute or eruptive stage of the disease only. There's a negative Koebner also described, that is the disappearance of lesions at sites of pressure, especially beneath the wash strap, and under the chapel straps, like that. This is supposed to be due to occlusion of the cutaneous vessels, thus stressing the importance of the vascular involvement in psoriasis. Then other types of Koebner, like pseudo-Koebner, that's development of warts or molluscum at sites of trauma, or photo-Koebner lesions developing on the exposed areas are also described. Who is this person? That is called Heinrich Auspitz, who describes the classical Auspitz sign in psoriasis. So this is a minute bleeding points when you remove the scales from a psoriatic plaque. So let's see how this is being done. The method is scales are completely scraped off using a glass slide. Finally, you will find a basement membrane which is exposed, seen as a moist red surface. That's called the membrane of Bulkley, through which you can see the dilated capillaries which are torn and present as multiple bleeding points. The mechanism of Auspitz sign is actually the pathological changes in psoriasis, like parakeratosis, the suprapapillary thinning, dilatation and tortuosity of the capillaries, etc. But this is not a sensitive sign because this is absent in other types of psoriasis like inverse, pustular, ectodermic, or guttate. And it's not a specific sign because it's seen in other conditions as well, like Dary's disease and actinic keratosis. So what's the role of candle in psoriasis? Bone scratching, and when you remove all the psoriatic scales, you will find that there is a shiny candle-like surface that's described as the candle grease sign. This is, you can see, scraping the lesion with a glass slide. This test is known as the grattage test. Let's see what happens when you do the grattage. This is done when there is no evidence scales clinically. When you scrape, the scales will come off profusely, like a coherence of scales will be seen. And this mimics the, as one has scratched a wax candle. And this is described as the candle wax sign or sign de la tachydibutia. Coming to morphological variants of plaque psoriasis, here you can see a thick hyperkeratotic lesion, which rather like a ring with a peripheral thickening. And the central part is slightly flattened or concave, resembling the oyster shell. That's the ostraceous or oyster-like lesion. So that's the oyster, and the oyster shell, you can see thick lesion with a surface slightly concave. Now, what's this limpet-like psoriasis? That is thick adhering lesions of psoriasis mimicking limpets. So limpets are actually marine mollusks, or snake-type lesions. They are usually very adherent to the underlying rock. So lesions mimicking exactly like that, you can see. very adherent lesions of thick hyperkeratotic leaf scales. Sometimes you may find large, persistent, thick plaques involving sometimes one limb or one large area, described as the elephantine psoriasis. Here you can see some conical lesions. Scales are thick and resemble cone-like conical appearance, having a conical appearance due to the heaped up scales. These are described as the Rheumatoid psoriasis. Some unusual patterns of psoriasis have been described in HIV also. The thick hyperkeratotic ring-like lesion. And another ring-like lesion, this is usually seen in a subsiding psoriatic plaque because lesions first subside in the center and the margins will disappear only last, leaving such a ring-like appearance. The typical scalp psoriasis, well-defined plaques with silvery white scales. Sometimes you may find thick asbestos-like scales, which has been described as tinea amianticia. But it's actually a misnomer because it's not a tinea. Guttate psoriasis is characterized by a shower of small lesions, pinpoint to raindrop-like lesions. The size usually vary from 2 to 3 millimeters to 1 centimeter, usually seen on the trunk and proximal extremities. The incidence is supposed to be 2% of all cases of psoriasis. And this is the types usually seen in children and young adults. And this usually follows the streptococcal infection. It's derived from the Latin word gutta, means droplet. Coming to inverse psoriasis, also known as intertriginous or flexural psoriasis, usually affecting the axillae, groins, cubital and popliteal fossae, umbilicus, and the perianal regions. The characteristic features are the intense erythema and very little scales, unlike the other typical lesions. So hence, this may resemble other conditions like intertrigo, seborrheic dermatitis, erythrasma, or candidiasis. Coming to erythrodermic psoriasis, there are two forms of erythrodermic psoriasis. Sometimes this chronic plaque psoriasis can gradually become generalized, involving more than 90% of the body surface, like this, making it a erythrodermic type. Or it can be a sudden onset of generalized erythema and scaling, presenting as a erythrodermic or the exfoliative type of psoriasis. This is usually precipitated by various factors like steroid withdrawal, topical irritants like tar and other agents, severe stress, focus of infection, drugs like antimalarials, lithium, sulfonylureas, and hypocalcemia. This is a potentially life-threatening condition, can get systemic complications, cardiac and renal problems, and may even endanger life. The pustular psoriasis are mainly two types: a localized pustular psoriasis, also known as ectodermatitis, and generalized pustular psoriasis. Localized pustular psoriasis, again, there are two types. One is the palmoplantar pustulosis, like this, mainly affecting the hypothenar and hypothenar eminences. Can also get throughout the palms and the insteps. These are the commonest sites, characterized by numerous sterile, yellow, and deep-seated pustules, which gradually evolve into brown crusted lesions. And finally, you will see the typical psoriatic lesions. This is the second type of ectodermatitis or localized pustular psoriasis, known as the pustular psoriasis of Halopo. Dermatitis repens is used as a synonym nowadays. This can involve either the tips of the fingers and toes as acropustules, or can extend to the dorsum of hands and feet. You can see here the subapical collection of pus, legs of pus. And when these lesions also, when the pustules subside, you will find the typical psoriatic plaques. So nail dystrophy and even loss of nails are very commonly seen in these types. Generalized pustular psoriasis, there are mainly three types: Wundt-Zumbusch type, the annular type, and the impetigo herpetiformis. The Wundt-Zumbusch type of generalized pustular psoriasis is a dermatological emergency characterized by sudden onset of generalized pustules, discrete or lakes of pus all over the body, along with severe constitutional symptoms like fever, malaise, headache, etc. And once the one crop will subside by superficial discommission, then other crops will develop like that. It will continue. It's also a life-threatening problem unless taken care early. Generalized pustular psoriasis of pregnancy is known as impetigo herpetiformis. It's actually a misnomer because it's not related to impetigo or even herpes. It's usually seen in the last trimester of pregnancy, but can occur anytime during pregnancy. Severe constitutional symptoms are developed here also. But if flexural onset is supposed to be very characteristic, usually start in the inguinocrural region and gradually spread. Start as small grouped tiny pustules, usually in a symmetrical pattern like this, and gradually spread. Here also, rarely you can get systemic complications like renal and cardiac complications. Lesions subside with reddish brown pigmentation. The next type is the localized form of GPP. Here, you get mainly generalized plaque psoriasis, and some plaques they turn into pustules. The localized pustule groups of pustules are seen. Other lesions will be just psoriatic plaques. Then annular type of generalized pustular psoriasis is characterized by such annular lesions. This can be seen during the acute, subacute, or chronic forms of generalized pustular psoriasis. The lesions start as a localized edematous, erythematous area, and pustules develop in the margins. This has been described by Lapierre as recurrent succinate erythematous psoriasis. Coming to nail changes, several nail changes have been described in psoriasis like pitting, onycholysis, that is distal separation of the nail, onychomatosis or the proximal separation, subungual hyperkeratosis, that is thickening of the nail bed distally, oil spot sign or the salmon patches, onychorexis, that's the longitudinal ridging, and total nail dystrophy. So nail pitting is supposed to be the commonest nail change seen in almost more than 90% of cases of plaque psoriasis and 60 to 80% of patients with a psoriatic arthritis. That's onychomatosis or proximal separation of the nail. Onycholysis, you can see the distal separation of the nail with subungual hyperkeratosis, that is thickening of the nail bed. Oil drop sign or the salmon patches are characterized by multiple brownish macules in the nail bed. This is due to the psoriatic changes in the nail bed underneath with a focal onycholysis. Psoriatic arthropathy is actually a spondyloarthropathy usually associated with skin lesions, nail changes, as well as sometimes the anterior uveitis. As the most common type of psoriasis associated with is the chronic plaque psoriasis. Nail involvement we have already seen about 60 to 80% of cases of psoriatic arthropathy. So according to the Mole and Wright classification, there are 5 different types of psoriatic arthritis. The classical type is the distal interphalangeal joint involvement seen in about 15%. So you can remember that the classical type is not the commonest. The commonest type is the mono or oligoarticular type, affecting 2 or 3 joints, especially the peripheral joints, seen in about 70% of cases. A rheumatoid type of arthritis affecting mainly the proximal indophalangeal joints, and the metacarpophalangeal joints can be seen in another 15% of cases. Arthritis mutilans is the mutilating type of psoriatic arthropathy, seen in another 15%, and the axial type with the spondylitis and sacroiliitis in another 50% of cases. So that's the sausage digits described in psoriasis. This is due to the dactylitis and the interphalangeal joint involvement. This is the most severe form of psoriatic arthropathy, produces such a deformity. Rheumatoid type of psoriatic arthritis, how can we differentiate from rheumatoid arthritis is the typical features of rheumatoid arthritis will be absent, like the Bertonier or the Swan-neck deformity. Swan-neck deformity will not be there. And the absence of rheumatoid nodules, absence of morning sickness, absence of rheumatoid factor, and the presence of the distal interphalangeal joints. So these are the features by which you can differentiate from the rheumatoid arthritis. These are some of the common radiographic findings in psoriatic arthritis. The earliest finding is the acro-osteolysis, which present as the fluffy changes in the tips of the phalanges. That's due to the destruction osteolysis of the terminal phalanges. This is followed by bony ankylosis. And the finding is the typical finding is the pencil in cup deformity. The tip of the proximal phalanx as a pencil, resembling a tip of a pencil, and the cup-shaped base of the distal phalanx. Opera glass joints are seen in the arthritis mutilans type only. And here you can see the fishtail appearance. That's the base of the distal phalanx. This just to show the pencil in cup deformity. It is a tapering end of the proximal phalanx and the cup-shaped base of the distal phalanx. That's the opera glass hand, such a deformed joints and bones. This is the picture of an opera glass hand. Here you can pull the finger pulled in and out. That's the characteristic feature. This is to the gross destruction and absorption of the bones. So what's the pattern of skin involvement in psoriatic arthritis? Usually, skin lesions precede joint involvement in about 70 to 80% of cases, approximately by 10 years. But in 15% of cases, both can occur simultaneously, arthritis and psoriasis. In another 15%, arthritis may even precede development of psoriatic lesions. So the most common type of psoriasis plaque of psoriasis in our psoriatic arthritis is the chronic plaque psoriasis. We have already seen that. Coming to mucosal lesions in psoriasis, these are described as the annulus migrans, may resemble geographical tongue, characterized by slightly raised annular, polycyclic or striped lesions of varying color, grayish to yellowish white in color. And other mucosal changes like a fissure tongue, gingival and mucosal lesions of similar lesions, and association with an inflammatory temporomandibular joint is also seen in about less than 5% of cases. Comorbidities are also common in psoriasis, like the metabolic syndrome and impairment of quality of life. So what's metabolic syndrome? It's actually a constellation of cardiovascular risk factors like obesity, hypertension, dyslipidemia, and insulin resistance. So the mechanism is supposed to be the overlapping inflammatory pathways as well as genetic susceptibility, which are the potential biological links for both these conditions. And various epidemiology studies have proved that there's a high prevalence of metabolic syndrome in psoriasis. Thank you for your kind attention.
Sir?
Okay? It's over.
Yes, sir.
Yeah, it's very good. Thank you, Dr. Najiba, for sparing a little bit of time from your regular schedule. We are grateful to you. I hope the postgraduates have benefited from your talk. Thank you once again.
Thank you so much. Great. Thank you all once again.
I think now we can welcome Dr. Lakshmi Shah from JIPMA. He is talking on pathogenesis of psoriasis. As we all know, Lakshmi Shah is a great teacher, and he has a very knack of putting very difficult concepts in any field in a very lucid manner. I welcome Dr. Lakshmi Shah Chandrasekhar for this.
Good morning, sir. Thank you for the very kind words. It's nice. It's a pleasure to be here. And thank you for the invitation. Am I audible?
Yeah, you are.
Okay. So good morning, everybody. Respected Crichton, sir, thank you for the invitation. And I'm going to talk about the pathogenesis of psoriasis. And as I said, I'll try to make it interesting, simple, and so that you can have some take-home messages. Okay, so before I start, pathogenesis of psoriasis, I think sir has given sufficient liberal amount of time. So I'll just take you through how psoriasis started. Long time back, people used to consider it as a disorder of the cell cycle, and that was there for a long time till cyclosporin came into existence. And the history of cyclosporin in psoriasis itself is very interesting. And I think is that I think it's 779, if I'm right. They found that a patient of renal transplant was on cyclosporin and also had psoriasis. There was a good response of the psoriatic plaques to cyclosporin. And from then onwards, they said, okay, this is not a disorder of cell cycle. This is also an immunological disorder. That there is a role for T cells here, because we know how cyclosporin works. It inhibits through interleukin 2, and it has inhibitory effect on T cell function. So with that, from a cell cycle disorder to a T cell disorder is what a serendipitous observation of cyclosporin in psoriasis taught us. Now, why would somebody think that there is a cell cycle disorder? And that is basically because the cell in psoriasis, there are a lot of scales. And why do we get scales? You get scales basically because there's increased cell turnover. So from a normal 28 days maturation which it takes, it happens very fast in psoriasis, maybe up to 4 days. So this increased turnover actually gave rise to that concept that it's a disorder of the cell cycle. Now, through the next 20 minutes or so, I'll try to take you through this journey of psoriasis. We started as a cell cycle disorder. Then it became a T cell mediated disorder. Then it was considered autoimmune disorder. Then it was considered an autoinflammatory disorder. And then finally, we realized that it's a combination of all these factors. So you need to have a genetic background. You need to have involvement of the innate immunity. You need to have involvement of the acquired immunity. And there has to be autoinflammation. All these three contribute and perpetuate the cycle of psoriasis. Now, let us just look into some of the data what we see. Suppose if a biopsy a psoriatic plaque, and this is what is called as reverse engineering. So we see the lesion, look at what is done, and think about what could have happened. So if you see this, when you do a biopsy, and it's very obvious, I gave you a clue that it's a T-cell mediated disorder. So we have CD3 cells. No surprise. Predominantly CD4 over CD8. No surprise. CD45, these are nothing but the memory cells. And you have to remember that there is a lot of memory cell involvement in psoriasis. There are circulating memory cells and there are resident memory cells. I'll talk a little bit about that later. So these are the predominant cells, that is CD3, CD4, CD8, and CD45. Now, if you look into the cytokines, and I'll talk about it. So you have the TNF alpha. FOXP3 is nothing but a regulatory protein. Then cytokines interleukin 17, 22, and interferon gamma. Okay. So these are the players in the game. And to the next 20 minutes, we'll try to find out how these players fit into this overlying milieu. Okay. So let's start about certain observations in psoriasis. Now, we know that psoriasis has two types, type 1 and type 2. Type 1 is the early onset psoriasis. In early onset psoriasis, that means age less than 40. Late onset is age more than 40 years. Now, why is that significant? Because when you have early onset psoriasis, you usually have the genetic risk allele HLA-CWCS. And I'll talk a little bit about that later. What is the significance of having this HLA-CWCS? Now, in children, it has been found, and all of us know that we give antibiotics for Petite psoriasis. And why do we give antibiotics? Because they have streptococcal infection. There is an overlapping of the M protein with the immune system. So there is something what is called as molecular memory, and that triggers off an inflammatory cascade. So now the question is, the tonsils are a rich source of, so they have lymphatic tissue, right? So let us look into this observation. So this is a small study, but where they perform tonsillectomy. So before tonsillectomy, if you look into it, so you have this homozygous and heterozygous. These are the variants, and this is the wild type, which is negative. So if you look into it before them, the individuals needed some sort of therapy. But after tonsillectomy, you find requirement for topical therapy, especially among homozygous, is almost nil. So which means that if you remove the foci of that tissue, that there has been some response in patients with psoriasis. Now let's see quantify it. And so now you see that you see this blue is the homozygote. This is the heterozygote, and this is the negative. And let us see the capacity. So this is 90%, 75%. So those who are homozygotes, that homozygotes means they have the CWC risk allele, both the alleles. Heterozygote means only one of it has O6, O2. Wild type means it doesn't, both the alleles don't have. Now, if you see in those where tonsillectomy is done, see the percentage improvement is almost 90% and maintained at 24 months. In heterozygous and in case of wild type, you find that this maintenance is not there. So basically, what does it suggest? This suggests that in patients who are homozygous for CWO6, they could benefit from tonsillectomy. Now, this is a very interesting, a combination of the genes, a combination of infection. So if you take care of those, the nodes, that is the lymphatic tissue as the tonsils, you could find that there is an improvement. So as I told you, three important things: autoimmunity, autoinflammatory, and environmental and complex genetic factor. So all the three components are there. There is not one single method or one single mode where you can get psoriasis. It is very, very well known. Let us look at it. If you start with the master, that means you are at risk for psoriasis. And how are you at risk for psoriasis? Because you acquired the genes, which are which make you susceptible to psoriasis. But genes themselves do not cause psoriasis. There has to be an environmental component. That is what is called as the epigenetic component. And how do we know that? So, for example, patients with smokers, patients who consume alcohol, patients who have higher body mass index, they have poor outcomes in psoriasis. So, these are the epigenetic factors which alter the risk of having psoriasis. Now, we know all this, that there are various susceptibility loci. The most common one is the source one. What do you mean by source one? Source one is actually the HLA-CW6. Now, as we know that this is the one which is responsible for almost 60% of the variants which have been found to be associated with psoriasis. And this has been validated in most parts of the world. So it's very important to understand that this is not something which is specific for a particular region or a particular ancestor or a particular ethnicity. It is present in most of them. Now, there are so many of the sorts which have been identified, but of significance are source 1, source 2, and source 4. Now, what is source 2? Source 2 is the one which is associated with the CAR14 gene. Now, the CAR14 gene, and I will talk about it, that is also a member of the innate immunity. So, this is responsible for what are called as monogenic variants of psoriasis. So, let's think about it again. Now, here you have involvement of the innate immunity also. It is not only the adaptive immunity, it is the innate immunity also which is involved in this. And the third one, which is associated often, is the source 4. Source 4 corresponds to the late corneal envelope, that is LCE. So, deletions of this have been found to be associated with psoriasis. The rest of them, they have been associated, but most important are the source 1, source 2, and source 4. Source 1 is for the CW6, source 2 is for the CAR14, source 4 is for the late corneal envelope. So, in patients who have these loci, they are more susceptible to acquire psoriasis. But then, only having the genetic component is not sufficient. Now, let's look at some data from India that is on HLA-CW6. So, this is a study from Dr. Rene George's group, where they actually looked into the clinical profile of childhood onset psoriasis and prevalence of CWP6. So, what they found out is, among Indian patients with childhood onset psoriasis, they have earlier disease onset, and most commonly HLA-CW6 was associated with gutted psoriasis, scalp involvement, and disease severity. So, three things: gutted psoriasis, scalp involvement, and disease severity. This is very, very similar to what has been reported in world literature. In addition to world literature, you also have nail involvement. Now, this is a paper from our group. Actually, we did a study on around 365 cases of psoriasis and 360 healthy countries. So, what we saw that there's an increased risk, that is 3.5 times higher odds ratio of having psoriasis compared to those without. And among psoriasis, there was association of HLA positivity with females, early age of onset, and this also suggests that HLA-CW6 is an important risk allele in patients with psoriasis in our population. Now, let's look at some other data on Indian data, which looked into late corneal envelope. So, here in the LCE3 deletion, so there is an increased risk of psoriasis due to the combined effect of both source 1 and source 4. That is, you had HLA-CW6 risk allele and you had LCE3 deletion. So, when you have combinations of both, there's an increased risk of psoriasis. So, this has been, this is again from the Kalyani. So, and this is again a large study which had more than around 700 participants. So, these are some of the major studies which have come on the HLA-CW6. Hello.
Doctor, I muted all. Kindly unmute yourself and speak, doctor.
Okay, is it audible?
Yes, doctor, it is audible.
Yeah. So these are the three major reports, and I've covered that. Now let's go to SORTS2. SORTS2, as I told you, is card 14. So what does it do basically? It's a member of the innate immunity. So whenever it recognizes something foreign or some microorganism, it sends danger signals. And how does it send? It activates the nuclear factor kappa B. And when nuclear factor NF kappa B is increased, what happens is it activates the keratinocytes to release interleukin 8 and a chemokine CCL20. And what else it does? It recruits inflammatory cells. Now, why is it important? CAR14 normally in adult psoriasis is important, but in familial psoriasis or familial psoriasis with PRP-like features, you can consider CAR14 mutation. So they will have features of both psoriasis and PRP, early onset of disease, facial involvement, family history of psoriasis or PRP. So again, I repeat. So these are characterized by features which have both psoriasis and PRP. They have early onset disease, facial involvement, family history of psoriasis, or PRP. So it's important to understand this. But again, it's a small component because monogenic psoriasis is not that common as compared to autoimmune or autoinflammatory types of psoriasis. Now, the other type which we can get is again a type of pustular psoriasis. Now that happens not due to CAR14, that happens due to interleukin 36 receptor mutations. So whenever you have a mutation in interleukin 36 receptor, so this leads to increased production of interleukin 8, and that results in activation of neutrophils, recruitment of neutrophils to the site, and inflammatory response. So this is again one more mutation. So sometimes some of the mutations associated with genetic forms of psoriasis include CAR14. It can also include interleukin 36 and also APS1. These are the common mutations which are responsible for monogenic forms of psoriasis. Now, let's go to the conventional types of psoriasis. See, the basic thing is you have a genetic background and then you have stresses. Now, stresses could include various things depending upon what. Like, for example, in children, it could be school, separation from parents, trauma, infection like streptococcal infections, drugs like lithium, beta blockers, etc., obesity, and sometimes even also the skin material. So you have these various stresses in a background of in a genetic background. So let's just keep in mind. So you have a genetic background, and now you have these stresses. So anything autoimmune condition should have an autoantigen, isn't it? So the various autoantigens, but I think the most important one is cathelicidin, that is LL37. Now, what is cathelicidin? Cathelicidin is nothing but an antimicrobial peptide. These are also members of the innate immunity. They are produced in response to stress, infection, etc. Then the other proteins which have been described are keratin 7 and the melanocyte antigen ADAMTL7E5. Right? But I will concentrate on LL37, which is nothing but cathelicidin. Now, yeah. So when we talk about chronic plaque psoriasis, so before I'll just give you one point which for you to remember, and we can discuss this later. Just keep in mind that chronic plaque psoriasis is actually TNF alpha, interleukin 23, TH17. Acute psoriasis, like the gutted variant, is interferon 1. And pustular psoriasis, interleukin 1 beta and interleukin 36. Just keep this in mind because this will help you to understand the further cascade and sequence of events. Okay. Now I'll just repeat the whole thing again. So the first thing what happens here is, so there is a background. Then you have some triggers, and I described those triggers. It could be trauma, it could be infection, etc. So what happens is this will stress the keratinocytes or damage the keratinocytes. Then that will expose the autoantigen. So which is the autoantigen which we talk about is LL37. Sorry, yeah. So what happens is when there is damage to keratinocytes, so some sort of self-DNA and self-RNA is excreted out. So then this LL37 recognizes this and forms a complex of LL37, where is cathelicidin, with the self-DNA. So what happens? So when you have this allele37 that's catheterized with the self-DNA or even a self-RNA, the body recognizes this as foreign. So then what does it do? Then the innate immune system gets into the play. Now, which are the members of the innate immune system? The classic members are the dendritic cells. Now there are two types of dendritic cells. One is the plasmacytoid, and then you have the myeloid. So what does the plasmacytoid do? They look like plasma cells, right? They look like plasma cells and they secrete interferon alpha. So the plasmacytoid dendritic cells, on top of the surfaces, they are these signals or these antennas. What do these antennas do? These antennas look out for all these complexes. So what happens? What are the antennas? Toll-like receptors. So these are the toll-like receptors. So you have toll-like receptor 7 and toll-like receptor 9. So it all depends. 7 or 9 gets triggered off depending on whether it is self-DNA or a self-RNA. Now, when this allele37 DNA complex goes, the toll-like receptor binds to, that is TLR9, binds to this self-DNA allele37 complex. And once it recognizes the plasmacytoid dendritic cell, its function to release interferon alpha. It releases interferon alpha, which activates another dendritic cells called the myeloid dendritic cells. Now, these dendritic cells, what do? They carry it to the lymph node and activate the NAV T cells. But by themselves also, they can produce a set of cytokines. For example, they can produce interleukin 12, which activates a Th1 response. It can produce INOS, or it can produce TNF alpha. But I will talk about it. So from the myeloid dendritic cells, it goes to the lymph node. Now, what is that in the lymph node? A naive T cell. The T cell doesn't know what to do. But once this antigen presenting cell is presented to the T cell, then it starts recognizing them as foreign, and then you have inflammatory cascade. So the naive T cell is no longer naive, it's programmed. And there are various types of programming. For example, it can be programmed to a Th1 lineage by producing through the help of interleukin 12. And this interleukin 12 is produced by the myeloid dendritic cells. It can be programmed to a Th17 cell by interleukin 23. Or even it can be programmed to a gamma delta cell. So what has happened is a naive T cell has got converted into a differentiated T cell. So the predominant two types of T cells are the Th1 and the Th17. Now, the other thing is that this myeloid dendritic cells also produces TNF alpha, which acts on the endothelial cells. And I'll talk a little bit about this later. So to sum up this slide, so you have a trigger, keratinocytes are damaged. Once they are damaged, self-DNA is produced. Catholicidin, that is allele37, forms a complex with self-DNA. The plasmacytoid dendritic cells recognizes it as foreign, interacts through toll-like receptor 9, produces interferon alpha, activates the myeloid dendritic cell, which carries it to the lymph node, where it activates the naive T cell to a programmed T cell. So that is from naive Th0, it becomes Th1 and Th17. The cytokines involved are interleukin 12 for a Th1 lineage, or interferon gamma for a Th1 lineage, and interleukin 12 for interleukin 23 for the Th17 lineage. And this is important. So I already covered this: the plasmacytoid dendritic cell, the myeloid dendritic cell, and production of TNF alpha. Now, there are two important axes which happens, and this is something we have to remember, that once it produces, the two important axes are these. One is the IL-12-23 axis and the IL-17 axis. Now, why is it important to remember these two axes? Because we have blockers which can target these pathways. Now, let us see what is the importance of it. So we know that I told you that Th1 response is there and Th17 response is there. Now, if it just, and why do we, initially it was believed psoriasis was only a Th1 mediated disease, right? And then later we realized that even if you block the Th1 pathway, it is not necessary that they go into remission. So later we came to know that the Th17 pathway is probably more important than only the Th1 pathway. So that there are two axes. One axis is the IL-12-23 axis. So what happens in IL-12-23 axis? What happens if you activate it? That is IL-12 will bind to the IL-12 receptor. Once it binds to the IL-12 receptors, it phosphorylates the JAK, and there's phosphorylation. JAK pathway gets activated and it results in production of interferon gamma. So this is the Th1 response. Now remember, IL-23, which is produced by the myeloid dendritic cells, will activate the IL-23 receptors, passes through the cell membrane, activates the JAK pathway, and produces interleukin 17. So this is the Th17 pathway. So now we can see the dichotomy between the Th1 pathway and the Th17 pathway. Now, if you look closely into the Th1 pathway, the Th1 pathway, again, if you go back, the myeloid dendritic cells, they produce interleukin 12. Interleukin 12 produces Th1 response, right? Now, how does it do it? It does it through the nuclear factor kappa beta, NFK. Now, this is very, very interesting pathway. So you could block the TNF alpha receptor. You could block the soluble TNF alpha. Then you have small molecules, that is the phosphodiesterase inhibitors, which will prevent activation of the nuclear factor kappa beta. That is like apramidast. And then we have the cytokines, which you can block. So this is the TNF alpha pathway. Now, I told you that I just told that there is stimulation of a naive T cell. So what happens is at the level of the node. So here you have the myeloid dendritic cell or the antigen presenting cell, and here you have the naive T cell. So what happens is that, and this antigen presenting cell presents that antigen, that is the LL57 cell DNA complex. It presents it to the T cell. It's already recognition of the foreign. So once it binds to it, there is stimulation and co-stimulation. And this results in the production of further cytokines, either Th1 or Th17. So initially, when the first biologics were discovered, only this pathway was very well known. So there were many drugs which were used which block this stimulation and co-stimulation pathway. For example, you have aliphasin, LFA3, CD2 blockers. But of course, now they are no longer CTLA4 inhibitors. Afalizumab, LFA1 inhibition. So, but these molecules, afalizumab is no longer used. So most of these have gone out of favor. But initially, what was thought is if you block the stimulation and post-stimulation pathway, it will help in remission of psoriasis. Then there was another side pathway which I didn't show you. So what has happened is again, antigen presenting cell goes to the lymph node. So once it presents to naive T cells, then there is the naive T cells get activated. But when they're activated, they must go through the bloodstream, isn't it? And that is what happens. So when you have an activated T cell, that is CD45RO+, it has to go through the bloodstream and enter the circulation. How does it happen? That can happen only when there's upregulation of these following molecules, selectin and the addition molecules, VCAM and ACTIN. Right? So this goes, binds, and then it's trapped, rolls, and then enters the circulation. And that's very, very important. And from circulation, it enters the skin. So this is another pathway which is stimulated by the TNF alpha pathway. So in case if you want to remember, this is what I said. That this pathway. Now again, I'll take you through this just to sum up and help you. So this is a stress, activation of dendritic cells. If it activates interleukin 12, there is a Th1 response, you get TNF alpha. If it other option is it produces interleukin 23, it activates the T alpha 17, produces interleukin 17, but the end result of both is inflammation. Right? Now, the thing is, look at this dichotomy. I mean, you have many targets. Say, for example, you could block the IL-12, that is of course the or you could block the TNF alpha, that is like etanercept, infliximab, or you could block the interleukin 17, like produlimab, izokizumab, and sectin, or the P19 inhibitors like IL-23, like ruxolitinib. So there are this dichotomy, that is the Th1 and the Th17 pathway, is what we have taken advantage of to use biologics. But the end result of inflammation is immune cells accumulate, they go through the bloodstream, and then they enter. So there will be systemic involvement as well as local involvement. So the end result is the same thing. The end result is what happens is when it activates TH17. So it activates a cytokine called as IL-17 and IL-22. So what is the function of this IL-17, 22 and predominantly 22 is hyperplasia. So this psoriasis of hyperplasia is predominantly caused by IL-22. But remember one thing is, see, and you see the beauty from here. From here again you have other loops because you stimulate the keratinocytes. Now the keratinocytes also they start producing local cytokines. So they also produce chemokines, CXCL1, CXCL20, etc., which perpetuates the whole immune response. And that is why you call it auto-inflammatory. So later, even in the absence of the antigen, because the keratinocytes are stressed and inflamed, they start producing these cytokines, and that results in auto-inflammatory process. So you have an autoimmune and an auto-inflammatory process against the genetic matter. So again, making it very, very clear, catalycidin and defensins, and I'll talk about a little bit about defensins later, activate plasmodiaphysin cells, interferon. Now, I'll just talk to you about this. So for example, this pathway is actually involved in what is called as acute psoriasis or early lesions of psoriasis or inflammatory variants or gutted psoriasis. They produce interferon alpha only. So in case of imiquimod treated mice, you actually get this part. Okay, so this is very, very important to understand. I'll talk a little bit about this later. Now, IL-17, and I told you how. So from the myeloid dendritic cells, stimulates an IT cell, produces IL-17 and IL-22. This I have already covered. It is produced by the TH17. The receptor is present on the keratinocytes and is responsible for hyperplasia. Now, there's a role for dendritic cells. I already covered that. That is antigen present converts naive to mature. And the two types of cytokines produce both 12 and 15. Now, I come to another important component of this is the antimicrobial peptides. Now, again, these are members of the innate immunity. They produce in response to infections. For example, the defensins, catalysts, S-android. Now, let's think about it. Why are they important? Now, let's go back and see some clinical observations. Compare atopy with psoriasis. You know that atopy is a lot of secondary infections. Psoriasis, we don't have it. Why is that? That is because the beta defensins are activated. There is copy number variation. There's mutation causing copy number variations, producing beta defensins, which are increased in number, which are reduced in case of atopy. So that's the reason why we get more infections in atopy and lesser in psoriasis. Now, catalysin, I already told you, stimulates the plasma and dendritic cells, but the human beta defensins, they can be activated by human necrosis factor alpha and interleukin 17. I'll just show you that pathway in case you don't remember that. Okay, sorry, I think I just missed that out. Okay, so basically what happens is, okay, sorry, I think I just missed that out. Yeah, so the human necrosis factor alpha and interleukin 17 and interleukin 23, which are produced, they activate the keratinocytes to release the antimicrobial peptides. But they can also be released from other cells. It can be from the monocytes, it can be from the macrophages, it can be from neutrophils. So the multiple inflammatory cells which can release these beta defensins. So upregulation of beta defensins, and this will further activate the keratinocytes. Again, there's another loop which is formed by these beta defensins. Now, the keratinocytes. Please don't think that keratinocytes are innocent bystanders. Keratinocytes are immunomodulatory. Keratinocytes can also act as antigen presenting cells. After they're inflamed, they act as antigen presenting cells. So they cause autoinflammatory loop. And cytokines released from keratinocytes are because VEGF is released, INOX is released, so they act as pro-angiogenic elements. Now, so I think is that it's always a three-way balance: type 1, type 2, and type 3. But in, of course, psoriasis typically type 1 and TH1 and TH17. Now, the important things are regulatory cells. there are problems with regulatory cells. These T regulatory cells are the ones which keep the autoimmune mechanisms in check. In case there is failure of regulatory cells, you have autoimmunity. Another important thing in psoriasis, if you think about psoriasis, it occurs on knees and elbows, and when it relaxes later, again you have it on the knees and elbows. And why is that? There's something called as resident memory cells. Even after long-term treatment, the CD8 positive, 103 positive cells are still there, and that is the reason why you get psoriasis in those sites which have prior been infected. Keratinocytes can both be the driver as well as the mediators. Now, the last one which I want to talk about is the microbiome. Now, I'm not going to talk too much about the microbiome. There is a thing that is, we really don't know whether the altered microbiome is a cause or an effect. One thing we have to remember is the microbiome is altered in psoriasis. They produce these pro-inflammatory lipids like butyric acid and fecalibacter. So once the butyric acid is increased, they are pro-inflammatory, and this further worsens the cascade. So I think to sum up, three major things one needs to find. There is a genetic background. Three major things: source 1, source 2, source 4. 2, the autoantigens, keratin 5, IL-37, and myelocyte protein, ADAMTSL5. Then the two cytokine pathways, Th1 pathway, Th17. Th1 is through interleukin-12, Th17 is through 23. Finally, the two important things are 17 and 22, which enter the epidermis, and they stimulate the keratinocytes. Keratinocytes can function as both mediators as well as drivers. They create a vigorous, vicious loop, which are responsible for maintaining the autoinflammatory. Last one, innate immunity is involved. Mechanism binds to the cell DNA. Beta defensins are upregulated, and they are stimulated by these upregulated cytokines, which further worsens the cascade. And there is copy number variations in beta defensins, which are also responsible for increased amounts of vitamins. Altered microbiomes are associated with psoriasis, but we really do not know whether it's a cause or an effect. So I think with this, I close, and thank you for your patience here.
Thank you, Dr. Lakshmi Shah. It's a wonderful talk. And of course, the postgraduate students need to revise or need to go need to study a little more on the pathogenesis further. They should know the basic immunology, the basic genetics, and the other factors involved in psoriasis. But definitely, they will be benefited once this presentation in mind. If they read a little more, they will understand it beautifully well. Thank you, Dr. Lakshmi Shah, for your beautiful lecture. Thank you.
Thank you.